30 minutes. He otherwise has no symptoms. His pulmonary function testing demonstrates FEV of 86%, FVC of 100%, and FEV1 over FVC of 64%. Which severity category does he fall into?
Moderate, right? Right? Okay, so there's another classification of severity based upon the lowest level of treatment required to maintain control. Remember, the goal is to get the patients off the steroids, but when you can't get them off the steroids, you really have no choice. Now we have more and more medicines. We have, the leukotriene inhibitors like Singular and what's the name of the other one? Montelukast and what's the name of the other guy? Yeah. So, like back in my days, I learned about theophylline. You guys don't have to worry about any of that stuff.
Some elderly are still on theophylline though? Is that right?
Some people, they still give them, some physicians that are old school, but with the medications you guys have, you don't have to worry about any of those things. But, so basically, this is basically the treatment. It's easy to remember, like the intermittent, you just give them an albuterol. That's it. I have intermittent asthma. So classification, mild, you give them low dose of inhaled corticosteroids, or you can use like alternative cromolyn or leukotriene receptor antagonist, Singular or any of these ones. But if you have persistent, then that's when you start thinking about like the low dose of the inhaled corticosteroids plus the long-acting beta agonist, or more steroids, or you do medium steroids plus the long-acting beta agonist. For those patients that are having severe symptoms, you can't get away with a high-dose inhaled corticosteroids. Remember, the oral steroids are only reserved for flares. You never treat long-term asthma with steroids. It's just not the way that we do it. And like I was telling you, if you see a guy on theophylline, it's because he probably went to med school long time ago. So now you guys have like this new monoclonal antibody. I think it blocks, I want to say the TNF. Let me just look it up real quick. It's called Xolair. It's very expensive, by the way. Inhibits IgA binding to mast cells and basophils, decreasing mediator release, and it works pretty well for urticaria, asthma, decreasing free IgE levels and down-regulating the IgE receptors. And it's FDA approved for allergic asthma, chronic idiopathic urticaria. No, it's a sub-Q. It's a monoclonal antibody.
Oh.
Yeah, this one is a monoclonal antibody.
So it would be like monthly or weekly?
Exactly. It's actually Q 2 to 4 weeks. It's like patients with rheumatoid arthritis, they get an Enbrel or Humira. Yeah, this technology, it really transformed the way we practice medicine. Now we have like monoclonal antibodies like for severe dyslipidemias. We have it for many different rheumatologic disorders. We have it like for cancer. We have it for immune therapy. Have you guys heard about immune therapy? Have you guys heard about cancer, right? You guys know President Carter, right? Jimmy Carter?
Mm-hmm.
He was cured from stage 4 melanoma, which was completely unheard of 5 years ago. So if you guys want to learn about it, there's actually a very elegant paper that is readable. It's not very dense. I read it the other day. The New York Times. Just write in the search bar like immune therapy. It's so promising what's happening out there. Like now they're actually treating even stage 4 lung cancer. They're doing all these trials with this medicine that actually saved Jimmy Carter's life. But it's you guys are born. You guys went to school in such a fascinating era where like diseases that, for instance, like hepatitis C. I would have never thought we were going to be able to cure that. I saw so many patients die from it, or like severe complications. Now it's all my patients are coming to clinic. Yeah, I completed 12 weeks. I'm clear. I'm like, wow, this is fascinating. It's amazing. You know how much is each pill, by the way?
Oh, it's like 80. Well, the treatment is like $80,000.
Yeah, it's $1,200 per pill. Yeah, it's crazy. Yeah, it's insane. So, like things like that, you probably are going to see a cure for HIV in your lifetime. I'm hopeful. Alzheimer's disease is still a big challenge, but I'm pretty sure they're going to be able to do something now. They're identifying individuals at risk, and they're actually treating them with the same type of medication, like monoclonal antibodies, directed to that amyloid plaque that forms, and they've been able to have promising, like, preliminary data. The thing is that they're doing studies right now in regions where early onset Alzheimer's is endemic. Like, there's a town in Colombia actually that Kaiser is investing like a lot of money, because in that town in particular they have a bunch of people with early onset Alzheimer's, and it's just fascinating what's coming up. So this medication, like, reserved for severe cases because it's pretty costly, and like I say, is one of the IgE antibodies against IgE. So it lowers the IgE level. It's pretty cool. Okay, so intermittent asthma, like I said, normal PFTs, guys. You have really no limitations. That's another thing that they may give you on your boards. This guy's fine. This guy probably gets it when he exercises, or maybe once in a while when he's exposed to the triggerings. Intermittent albuterol. Mild persistent asthma, normal PFTs. These have very minimal limitations. Once in a while they cough in the evenings and they have 2 or more days per week of symptoms. You give them a little bit of inhaled corticosteroid. Moderate, again, it's more severe symptoms, daily symptoms, and you do steroids plus the long-acting beta agonist. You guys know which long-acting beta agonist we have? Formoterol, salmeterol, and formoterol. Yeah, so those are the 2. And can these medications increase your mortality? Like, if your patient is telling you, like, you know what, I'm using it a lot, what are you going to tell your patient?
You should alter the therapy, right?
You have to discourage them to do that, like, right away, because that's not a rescue inhaler. And these medications actually carry mortality, like arrhythmias and significant bad side effects. So if your patient is on a long-acting beta agonist, they should never be using it as a rescue therapy. It's albuterol. That's it. And severe symptoms, like I said, we have all these beautiful available therapies in addition to the high-dose inhaled corticosteroids. We have many different ones. You know, I use Qvar usually to begin with, but we have budesonide. That works pretty well. Okay, so we also have the asthma mimickers, what we call the asthma syndromes that are not really asthma. So either we have like patients that just cough during asthma, aspirin-induced asthma. You guys remember on your boards they give you a patient with like allergies, nasal polyps, and aspirin-induced asthma. So you may get that one. It's like an asthma syndrome. You get the exercise-induced asthma. That's the one I have. Occupational asthma. I mean, obviously you have an environmental trigger, and this one is common in the medicine boards. I don't know if you guys get it, but it's usually allergic bronchopulmonary aspergillosis. It's important that you identify it because you need to figure it out where is this patient getting it from? Where is the source of the aspergillosis? Because it's not actually a infectious disease. It's just the exposure to the antigens produced by the aspergillus that causes a lot of asthma. So occupational asthma, you have like it's common. You know, you have like the occupations usually that they describe you as like millers and bakers. These patients, they have like classic exposure. On your boards, you don't have to worry about it. Again, I think the boards are pretty fair. They give you a good history, and they're not going to give you a point in between. If they're giving you this kind of history, you already know what you're dealing with. But the interesting thing is that there is a occupational asthma with a latency period. So most of these antigens are high molecular weight antigens, and it's usually IgE mediated. And these patients usually they have like like I say, a latency period where the symptoms present, versus you can have occupational asthma without any latency period, and you get reactive airway disease like right away, and they're usually smaller molecular weight. But I don't think you need to know any of these things. But COPD, we have many Americans with this, and it's growing despite all the aggressive. Fortunately, like what research shows is that the smokers are decreasing, but it's sad to see like young people like you guys are still smoking. I'm pretty sure you have somebody in your class that smokes, and I always find that like out of your mind, but you know, people do silly things. But COPD is actually a lot of the patients can be younger than 65. It's a very costly disease, and you can tell like the estimated like cost for Medicare is like basically billions of dollars every year. And our job is to educate your patients, because there is always a benefit to stop smoking, even if they've been smoking for many years. The benefits are immediate when you stop smoking. So you need to counsel your patients.
I'm sorry,
Yeah, go ahead.
Is the data since 2005, like, is it showing still a growth in COPD cases, or is it starting to?
I think it's starting to stabilize, but it still represents a significant burden.
Yeah.
You know, like not necessarily just smoking, because we have a lot of other exposures that can cause COPD. Occupational, or patients that they actually cook with kerosene, like the gasoline, or like people actually that they cook with firewood. We still see a lot of people in rural areas getting exposed to this kind of stuff. And it's actually the more dramatic thing is that it's the second leading cause of disability behind heart disease. It's pretty impressive. So the risk factors, we know that there is tobacco primarily, but you also have genetic factors. They may give you an alpha-1 antitrypsin deficiency. You guys know what other disease is associated with alpha-1 antitrypsin deficiency? There's cirrhosis. There's a form of cirrhosis associated with alpha-1 antitrypsin deficiency. Males more at risk than females, but that's changing because the smoking rates are equalizing between males and females. And another risk factor is that you had asthma as a child, or you were a premature baby. Prematurity is actually associated with a bunch of medical problems. This is one of them, and also kidney disease. You can have actually FSGS associated with prematurity. This is actually a good slice to show that the rehabilitation, when you stop smoking, actually this is a good point, like this is the normal lung decline as we age. This is the pathological lung decline associated with COPD, and there is hope for these patients when they stop smoking and they do pulmonary rehabilitation. You can tell that the rate of decline is much slower. So make sure you counsel your patients about this, because very easily you can be reaching the line of disability. And you know, once your FEV is close to 40, that's when the patients they can't function. They cannot hold a job. They cannot do anything by themselves. There is a classification, the GOLD classification. I don't think you need to know this. Just think about like mild, moderate, severe, and very severe. It's there for your review, but you're not going to be asked about the GOLD classification of COPD. Okay, so the treatment, smoking cessation. If you're going to prescribe oxygen, they cannot smoke. They can blow themselves up. And you're going to see that. And it's not even funny. It's actually, you can see that in clinical practice. And medical therapy, pulmonary rehabilitation, and it's getting more and more popular that the patients are getting lung volume reduction surgery, like I mentioned. And ultimately, patients can get a lung transplant. Do they need 2 lungs, or they only need 1 lung when they get transplanted?
But I guess if you could only get 1, it's better than.
Yeah, they get 2. They get 2, but they can only get 1. I mean, if it comes down to, yeah. So they do assessment like prior to surgery. They do very extensive, and they're able to selectively determine how much each lung is contributing, and they may just transplant the one that is more diseased. Yeah, it's like when they do a kidney transplant, they do 1 or 2 kidneys. They only do one, unless you're a child. I mean, they like a kid getting a transplant from another kid. They usually put both kidneys. Or for some patients that are like extended criteria donor, and the function is very marginal, sometimes they harvest both kidneys and they transplant them. But for the most part, they only get one kidney. Okay, so this is an algorithm. Basically, important things for you guys to know is that, like, patients when they have like smoking cessation, you vaccinate. This is mandatory for everyone, like influenza and pneumococcal. You guys know that we have two different pneumococcal vaccines. One is called Pneumovax, and the other one is called Prevnar 13. I don't know if you've seen the commercials. It was FDA approved as of December of 2014, and I give it to all of my patients. Usually you space them out by 1 year, and they're different because they have different polysaccharides and they confer different type of immunity. So the data is actually pretty good with Prevnar 13. So I think Dr. Ben-Zur is giving to his patients. I don't know if he's already getting it. Have you guys been giving Prevnar 13 or?
I've heard that it's available, but I'm not here.
Not here?
Not that we've seen.
Okay.
One of them is, I was under the impression that one was like for immune compromised patients and the other was elderly, or is it just?
Everybody with lung disease should get it. Like every patient, like after the age of 65, should get it. Or if you have a chronic condition. Chronic condition can be something as simple as diabetes. So, like pretty much you vaccinate a lot of patients against this because it's pretty harmless. Remember, this is a killed vaccine. It's not like a Zostavax or a shingles vaccine that can actually give you the disease. This is like the most common side effect is that the patient can have like a localized reaction. They can have like temperature or pain, but it's very safe and it really saves people's life. Like these patients with COPD, they should all get vaccinated.
So like an 8-year-old with type 1 diabetes, or?
I don't think they do it for peds. I don't think they vaccinate against Pneumovax.
So it's like
Yeah, for adults, I'm pretty sure like if you have a chronic condition, you can get it. Like at Kaiser, everybody gets it. Yeah.
And you give both separated by 1
Yeah,
year?
by 1 year. Yeah, you don't give them like back to back. You just do like 1 year separated. Yeah, so but this is basically the smoking cessation, supplemental oxygen when the patient has severe symptoms, or when they're like basically, or they actually get lung reduction surgery or lung transplant. But most of the patients are going to fall in this category here, and you treat them with Spiriva. This is the capsule. Have you guys seen Spiriva? Dr. Ben-Zur has it probably here. You guys don't have samples anymore, right? Pharmaceutical samples, or very little.
Oh no, they're up there.
Yeah. So if they have it, just take a look because the patient is pretty cool. Actually, it's like a little capsule. You open it. There's a puncture pin, and it makes a little hole, and then you inhale the content. Patients know it as the green pill. So it's once a day, and this really changed the way we treat COPD because prior to this we only had Atrofen, ipratropium, bromide. And Atrofen half-life is very short, it's like every 4 hours. So patients now, they just do like a once a day inhalation and you're good. And then we have the long-acting beta agonist. Like these are different long-acting. And if you take a look, try like Spiriva is always part of the treatment. If you take a look in the 3 different pathways, you always have Spiriva as part of the treatment. This company is probably making big money. Okay, so this is the annoying part. I'm going to cruise just to tell you that restrictive lung disease is any disease process that actually results in the decreased lung capacity. Remember, in one we look at, for the obstruction, we look at the FEV to FEV1 ratio. And in restricted lung disease, we look at the decrease in total lung capacity. So differential, like I said, is pretty big. A lot of things can actually cause that. So this is the classification. I still have time to remember all these things, and it's very annoying. Like, have you guys ever tried to read an ophthalmology note? You don't understand anything what they're trying to say because they use all these mnemonics or this like nomenclature, and you're like, I have no idea what you're talking about. Same thing with pulmonary. Like they have like DIP, RPIL, AIP. So I honestly, like, when I see that, I say like, okay, let me read the note. I hope they don't, like they're like sometimes they put COP, cryptogenic organizing pneumonia. So these are very different types of interstitial lung disease other than idiopathic pulmonary fibrosis. And it's funny because a lot of these things you treat the same way. You treat with steroids, but these are more like patterns, radiographic pattern. I'm going to show you some pictures. But the bottom line is that you have the idiopathic interstitial fibrosis, and you have the idiopathic pulmonary fibrosis that fall into this category. I'm going to show you some. So this is a normal X-ray. How many spaces? 1, 2, 3, 4, 5, 6, 7, 8. That's pretty normal. If you see more than 8, you start thinking, okay, this person probably has COPD. And then you see like a X-ray that looks a little abnormal because you see some interstitial markings. That's what we call interstitial. It's very different than the fluid. Like the fluid pattern is very different. Like we call that cephalization, and we call like you can see it right here around the pulmonary vasculature. And you can see like some haziness. That's when you start suspecting like, does this patient have some sort of like interstitial lung disease? Mm-hmm. And one of the favorite places for this disease process to start developing is in the lung bases. You can see here that it's not normal. Nasty. Yeah, it looks nasty and doesn't look normal. But to get a good history, you need to get a history about the occupation, if they're using any drugs, if they have any pets. The most common question on your boards is like, this guy has a parrot, and they have like, what's the name of the chlamydia shiitake, or what's the name of the...
Not PEs, isn't it?
Oh, yeah.
The most common, there's a random question with a parrot, like psittacosis or something like that.
Psittacosis, yeah.
Something like that.
Chlamydia shiitake, psittacosis is the name of the... So you always inquire about birds. Like, do you have any birds? Bird droppings?
Isn't there one by like the river swamps too or something?
The river
I don't know,
swamps?
I always remember getting that one and I like always get it wrong. It's like,
The river swamp.
Having to do with similar blood.
I'm trying to think which one. But it's more like a parasitic disease, or
It's more like
a
what?
parasitic disease, like a parasite?
I think so. I think it might be.
I think there's some parasite that can actually travel to your lungs, but it goes into the skin. I forget what the name is. It just travels to your skin, and then ascaris, like the first time you get ascaris lumbricoides, you get it. The cycle actually starts. I think you eat the eggs, and the eggs travel through circulation. It travels to the lungs, and it gives you a form of pneumonitis. And these patients, they start coughing like crazy, and then the adult parasites, actually they travel again. I don't know, I can't remember, it's been so long since I saw parasites. But anyway, so you asked about all these things: systemic symptoms, smoking, family history, clubbing. Have you guys seen clubbing? Not in real life, but pictures, yeah. Yeah, you haven't paid attention to your COPDers. So bibasilar rails, any signs of coral pulmonary, which is primarily like a right heart failure, just look like signs of right heart failure. Lymph nodes, rash, arthritis, and fever. This is more like for rheumatologic conditions. But this is complicated. Like I said, you're never gonna be like, what the hell is UIP, NSIP? This is beyond the scope of this talk. I don't think you need to review these things. But the bottom line is that you think about, this is infectious. This is basically possible interstitial lung disease. Then you start thinking about, okay, I need to do a high resolution CT of the chest. You guys know the difference between a normal CT and a high resolution CT of the chest?
Frequency of the slices?
Yeah, it's like a 1 millimeter cut. There's a lot more radiation. So you can do like a low dose. Like one of the tests that we do for screening, like you guys know that now we can screen for lung cancer with CTs. But we do low resolution CT. It's actually a changing practice, like from the US task force. Before we weren't screening for lung cancer, but they concluded that some population, they benefit from screening, including the smokers. I think like after the age of 55, you start doing like a yearly low resolution CT versus, this is very different. It's a high resolution CT that the pulmonologist, I almost never order these tests because if I get any of these things, I wouldn't know what to do with it. You know, when I hit this, I already know that I need to send this patient to a pulmonologist because I'm not going to be dealing with this. And sometimes the pulmonologist disagrees that why do you do that, and you know, it's a lot of radiation, whatever. So if you can't really figure it out at this point, I'm referring to a pulmonologist right here. Okay, so these are the same things that we talked about. Oops. Okay, so which is the earliest PFT abnormality seen in interstitial lung disease? It's a restrictive lung disease, right? Which one?
Vital capacity?
You said it's a restrictive, right?
It's restrictive lung disease. Remember we talked about the
Oh,
DLCO?
restrictive, sorry.
Remember the DLCO? So that's why the DLCO, you can see decreased vital capacity, but we're talking about like advanced disease. But that's why like pulmonary function tests, when they do the diffuse of like carbon monoxide, is very helpful because very early in the course of disease, you can actually see that there is a change in the diffusion of this gas. So that's one of the reasons why we do it. So it's the earliest sign if you have like a AA gradient or desaturation with exercise. You actually, these patients in very specific diseases, you can see like a mix. It's like an obstructive and a restrictive pattern. But if you have a patient with hypercapnia, like you do a blood gas and the patient is already retaining carbon dioxide, that's not good. That's actually pretty bad because that tells you that they already have like severe impairment. It's like a pre-terminal finding, pretty much. So in these interstitial lung diseases, the chest X-ray can actually be normal in most patients. I would say, like if you have like diffuse lung disease, like they have like 15%, 30% patients with bronchiectasis, you cannot find out just based on plain X-ray, and up to 60% patients of emphysema, you can read the X-ray as normal. So that's why this high-resolution CT is a much more sensitive, and it can provide confident diagnosis in about 50% of the patients. And you know, again, I don't do it because I'm not qualified and that's not the scope of my practice, but I want you guys to know that the usual findings are the ground glass opacity. So if you get on your boards that they're describing like there's ground glass, you already know that they're probably asking you a question about interstitial lung disease. You know, there's another finding that is called a honeycombing. I think I have a slide here. I'm going to show you. And the other findings there that you see like interlobular and intralobular septal thickening. So this is basically ground glass, very classic, very abnormal. You know, we don't know. You know, you see the thickening that they were mentioning, the interlobular thickening. And I actually have a picture here. This is also ground glass. I think I have another picture here. I will show you about honeycombing. This is honeycombing. You see?
The walls are breaking, like the alveolar walls?
They're breaking and they're forming like these fibrosis, these areas of fibrosis. That's pretty abnormal. When you see this, it's like some sort of interstitial lung disease. And that's not an infectious disease. Maybe like some variants of TB, it can appear like this, but it's mostly like some sort of immunologic process, interstitial lung disease. So this is, go ahead.
Sorry,
No problem.
Look similar on X-ray? Because these are just like tissue.
In X-ray is different. In X-ray actually honeycombing looks, let me see if I can Google a picture of an X-ray with, this computer has internet. Yeah, it looks different. You won't be able to see it this way, but it's more like diffuse. Yeah, but it looks different. This is a sagittal, no, this is a transverse cut. No, this is a sagittal, right? Yeah, this is a sagittal view of the lungs. So a lot of like honeycombing, very abnormal. So these are like different patterns, like again, pulmonology level. If the honeycombing happens in this area, you think about, okay, it's collagen or hypersensitivity pneumonitis or asbestosis or sarcoidosis. But if the distribution is more central or the upper lobe, you think about other disease processes. So again, it's impossible for you guys to memorize this. This is more like as a pulmonary fellow. But these are basically the how to interpret these things. In my internal medicine boards, I never really have to deal with any of these things. So I leave it there for your review. If you want to expand your knowledge, or if you have like a particular interest in this field of medicine. So diagnosis, you guys they do a bronchoscopy, bronchoalveolar lavage, and they look for either infectious versus non-infectious things like lymphocytosis, mast cells, or eosinophilia, peripheral eosinophilia. And they sometimes do a biopsy, but biopsy has limited utility because it only changes managements when you're dealing with like cancer, but most of the times the cancer is diagnosed in a different way. They actually do like either a percutaneous approach or they do like interventional radiology approach. Unless you're like an area that you cannot reach with a needle peripherally, but these days they're doing so many amazing things that I'm telling you, like interventional radiologists can pretty much put a needle wherever they want to put a needle. But if you're thinking, like, oh, this patient probably has interstitial pneumonitis, biopsies doesn't really change the management. So that's why this is another separate topic in pulmonology, like whether or not you do a lung biopsy, because a lot of the times it doesn't really change the management unless you're dealing with cancer or infection. Okay, so yeah, these are basically usual interstitial pneumonitis. These patients have pretty progressive course, and they die pretty much within 5 years. All of them are gone unless they get a lung transplant. It's like a type of this is how severe grand glass looks in an X-ray. This is pretty end stage lung disease. This guy, he needs a lung transplant as soon as possible. This is another case of the usual interstitial pneumonitis. It's pretty bad. This guy probably is barely breathing. Yeah, this is a progression over time. It's terrible, right? There's nothing you can do for these patients. You can give them whatever immunosuppression, nothing stops that process. It's very, very unfortunate because we don't know what causes it. So imagine like there's so many diseases that we still don't have a cure or even an accurate diagnosis. So these are basically like the natural progression of the usual interstitial pneumonitis. This is a histology picture. You see lots and lots of fibrosis here. And this is another type of pneumonitis. We already covered the specific. This is the non-specific interstitial pneumonitis. It's the second most common cause of interstitial lung disease or interstitial lung pneumonitis. The patients, they actually they feel like they have the flu. And I have patients like showing up in the urgent care, they don't feel well, and I send an X-ray, and boy, like that's as far as I go, because at least I know right away that this patient needs to be seen by a pulmonologist, because it's not like a typical pneumonia. Like the typical pneumonia patient is pretty straightforward. I got a cold, not getting better, I go in, I get an X-ray, and you see a consolidation, and that patient needs to be followed. But these patients, they come in because they're just not feeling well, and the duration of symptoms is like pretty prolonged. They don't have a fever, they don't look well, and the chest X-ray looks very abnormal. Especially you look for the lower zone. Remember that I showed you those reticular opacities in the lower zone? You can see this on the CT scan. Those patients, they definitely need to be like managed by. They need to be ruled out for scleroderma and some other rheumatologic diseases. This is another type of pneumonia, the cryptogenic organizing pneumonia. It was first described in 1983, and we know that these patients actually, they have, like more than 3 months of like all these symptoms, like chills, fevers, myalgias, very high inflammatory markers, and they call it cryptogenic organizing pneumonia because they have like areas of consolidation in CT. It almost looks like an infectious pneumonia, like a typical pneumonia, but like they also have like other interstitial lung disease findings, like the ground glass attenuation. And I have a picture here, so you can see like it looks like pneumonia, but the interesting thing is like you have like these patches all over. That's not like a typical multi-lobar pneumonia. And it's actually this is the histopathology. It gets even more complicated because this type of organized pneumonia, it has a very different, very broad differential diagnosis. It gets a lot more complicated. So again, completely out of the scope of your practice and my practice, so I'm not going to cover that. Okay, so this is I think this is autoimmune. No, AAP stands for, let me just got it here. I have to use my cheat sheet. Let me see. Acute interstitial pneumonia? Yeah, I think that's the one that's infectious. Let me see.
You weren't kidding about all this.
I wasn't kidding. It's at the end of the day, like you have to see a pulmonologist. That's how I see it. Yeah, if you guys are in urgent care and the X-ray doesn't look like classic pneumonia, you need to refer them. Yeah. So these patients, they have like, they have a pretty progressive course, and then the mortality is like about 50% after 2 months of illness onset. Yeah, we had a chest conference. I go to chest conference every Thursday. I present a patient with this, and they couldn't bring him back. So I want you guys to go home depressed about these weird diseases that happen to any of us, right? Okay, let me see if I have any other. Yeah, I want to talk about, like, this is probably something that you need to know, the subacute hypersensitivity pneumonitis, because this is related to either subacute or chronic. These patients actually, they have bronchiectasis, and this is one of the things that you can manage these patients by removing the antigenic exposure. So for instance, if you have a patient with, like, you're having the hypersensitivity pneumonitis to bird droppings, that's it. You just tell the patient you need to go live somewhere else, and that's how you get cured. So the diagnosis, the therapeutic trial is very easy. You just tell the patient, you know what, you need to abandon. And literally when it's related to birds, you need to get out of the house, because even if you get rid of the birds, you still have the antigenic exposure. So yeah, they presented a case the other day. They got like 30 birds in the house, and no wonder why he ended up having all these symptoms. Okay.
So would it just halt the progression, or would, in those types of cases, would there be any recovery?
100%. That's why they ask you so much about this on your boards, because it's so important that you identify that there is a hypersensitivity pneumonitis picture, because if you don't diagnose them on time, they progress to pulmonary fibrosis. So, and the improvement is dramatic. Like after a couple of days of being in a different environment, they start feeling better. And most of the times you don't even need to use steroids. You just need to remove the inciting agent. That's all you need to do. So that's why, like I was just telling you guys, maybe the previous group, acute interstitial nephritis, it's a form of kidney disease that is associated with an exposure to a medication, like either a PPI or a beta-lactam antibiotic or NSAIDs. So it's not common that we see that in clinical practice. It only accounts like for 3% of the acute kidney injury, but it's so heavily tested because it's so important that you are able to identify it, because if it goes unrecognized, the patients will progress to chronic progression of kidney disease and dialysis. So same thing happens with this. You see all these monocytes infiltration, a lot of like interstitial infiltration from the antigenic exposure. So sarcoidosis, you may get it on your boards. There's 4 stages of sarcoidosis. Like the first stage is just like perihilar lymphadenopathy. The other one is like more like progression, and this is like actually like end-stage lung disease. End-stage lung disease from sarcoidosis. Fortunately, sarcoidosis is easy to treat, and not every patient goes to end-stage lung disease. Have you guys ever seen sarcoidosis, by the way? Typically on your boards?
One of our new patients actually
Has it? Are they treating him?
Honestly, he would have a laundry list of medications. He had that and like 10 million other things.
Was he on prednisone?
Yes, he was.
He was on prednisone, yeah. So they're treating him. When you have a stage 1 sarcoidosis like perihilar lymphadenopathy, you don't necessarily need to treat them, but if they're having like progression or they have pulmonary symptoms, definitely they need to be treated. So So it's, like I said, like stage 1 is only the lymph nodes are enlarged and pulmonary function is perfect, and most patients actually resolve spontaneously. Is he African American, by the way, that patient?
He's
Caucasian, okay.
There was a famous African-American comedian, I'm blanking on his name, but I think he died of sarcoidosis a few
Really?
years ago.
Really, yeah, it's quite common.
He worked in like a construction kind of.
The guy was a construction worker?
Yeah, some sort of like, he was around some sort of environmental.
Yeah, we don't know what causes sarcoidosis actually. It's one of those things that it's just like a proliferation of the lymphatic tissue. It's not malignant. It's just like, it's a strange condition because sometimes it just goes away on its own spontaneously. Yeah, but stage 2 you have like the lymph node and inflammation is in the lungs and the PFTs are abnormal, and you can actually do a watchful wait because you still have a good chance that this is going to resolve spontaneously. Yeah.
African American and women?
It's more common in both African American and women.
Actually, there was a patient that he's saying that's African American and a woman.
Yeah.
Sarcoidosis. I remember she had prednisone on her, and I was like, oh.
She was on prednisone?
Yeah.
Yeah. Yeah, it's more common in African American females. And stage 3, like when you have stage 3, the take-home message is that if it's 3 and 4, you need to treat them. You need to treat them because these patients, they already have abnormal LFTs, and you know that the chance of a spontaneous recovery is very small for the stage 3. Like larger lesions, like 5 millimeter nodules. And this is probably another thing that's classic on silicosis. If you see, if they mention the eggshell calcification, always remember about silicosis. Eggshell calcification. You can actually see other tumors, already nodules that have this eggshell calcification. They need to rule out for malignancy. But if they give you several eggshell calcification, you think about silicosis. Okay. Okay. So progressive massive fibrosis is a pretty ominous complication of silicosis, and these patients they progress. Basically, they need a lung transplant. Okay. This is a very ugly X-ray of someone with progressive massive fibrosis. So this guy is respiratory failure, and you can see like the upper lung zones, they're completely occupied. And you guys understand why the upper part, right? It's basically, it's a very small particle, and this is what it gets. It doesn't go further, yeah. So the magic word for you guys is the eggshell calcification, okay?
And is that the calcified lymph node, is it just the particulate that's trying to be filtered out through the lymph node kind of accumulates and calcifies there, or is it?
No, it's just like your body's response. You start developing this calcification, but it's years and years. This is a very chronic finding. So you're gonna get tested on the coal miners worker, pneumoconiosis, also known as black lung disease, or anthracilicosis, the same name for the same disease. It's just like the rate and the quantity of dust accumulation is the most important factor in the pathogenesis. And these presentations are similar to silicosis, is simple chronic or progressive, pulmonary fibrosis. We also have the asbestos-related lung disease. Remember the lung plaques, the fibrosis, the asbestosis, and the pretty well-known mesothelioma that is a very bad cancer to have. The asbestos can actually form the pleural plaque. If you're given a question on your boards about a pleural plaque, immediately associate that with asbestosis. It actually is such a toxic mineral that up to 50% of the people that were exposed, they develop it. So I don't know if you guys know that the most recent construction codes, they prohibit the use of asbestos, but we still have a lot of places, like